Most students struggle with fluids and electrolytes, and I have found from my experience that this content especially must have a hook of clinical practice to contextualize this to the bedside. Today's case study is an unfolding clinical reasoning case study on diabetic ketoacidosis on a patient with a history of chronic renal failure. This is the ultimate fluid and electrolyte case study that will really help your students deepen their learning of this most important content of F&E to the bedside. Unfolding reasoning is my most complex level of the 3 levels of clinical reasoning case studies that I have created that students will help them to develop clinical reasoning and practice the thinking that is required for practice. Unfolding reasoning also has an evaluation component to see if a change of status has progressed or if the patient is improving. This case study can be purchased on my website at keithrn.com, as well as numerous other med-surg topics that are there to help your students practice the thinking to prepare them for professional practice. So let's jump in today's topic, diabetic ketoacidosis. History of the present problem. Diana Humphreys is a 45-year-old woman who missed her scheduled hemodialysis treatment yesterday and has been feeling increasingly nauseated the past 12 hours. She has had a harsh productive cough of yellow sputum the last 3 days. She checked her blood glucose before going to bed last night and it was 382. But then she fell asleep early and missed her bedtime dose of Lantus insulin. When she awoke this morning, she continued to feel nauseated and had a large emesis. Her glucometer was unable to read her blood glucose because it was too high. She took 10 units of Humalog insulin this morning. Her nausea has increased all morning and she has been unable to eat or keep anything down. When her lunchtime glucometer gave no reading because it was too high and out of range, she called 911 to be evaluated in the emergency department. The first component of clinical reasoning is the ability to identify what clinical data from that scenario is relevant and therefore has clinical significance to the nurse. So if we look at that scenario of a patient with a new presentation, what is relevant? Well, as we look at this, there's some things that I would want to highlight here. Number 1, she missed her scheduled dialysis treatment yesterday. Now, a patient who is dialysis dependent, what are the consequences of that to her physical well-being? Well, as we know, the waste products and electrolytes, especially the potential for potassium, are going to be off, as well as the volume status is going to be high, and fluid volume overload must be something the nurse must clinically consider. Secondly, she's been feeling more nauseated the last 12 hours. Now, nausea is a vague complaint, but in the context of knowing deeply the presentation of diabetic ketoacidosis, this is a red flag and a central component of a patient who presents with this presentation, but we need more data to make that confirmation. She's also had a productive cough of yellow sputum the past 3 days. Now, this combination of nausea, and what does the yellow sputum suggest? Well, it's obviously colored. Therefore, it's most likely a pneumonia of some kind. And as we know, if someone is diabetic and has an infectious process, this increases the likelihood of a diabetic developing diabetic ketoacidosis. She checked her blood sugar and it was 382. That obviously is too high before she went to bed, and she didn't get her Lantus. And as we know, Lantus is a 24-hour insulin. It's long-acting, and it's going to help lower that blood sugar, but if she didn't get it, her blood sugars are going to continue to climb. And she also felt when she woke up, she was nauseated with large emesis, and her glucometer in the morning was unable to read because it was too high. It must be known that most glucometer units have a high of 500. When it's over 500, it will not give a reading. So we can safely assume that she is clearly over 500, which is obviously too high. She took her 10 units of Humalog. As we know, that's a short-acting insulin this morning, but the nausea has continued, and she's been unable to keep anything down. Again, situated in her knowledge of DKA, that is a clinical red flag. And so you as the emergency department nurse now collect your first set of vital signs. Her temp is 101.6. Her pulse is 114. Her resps are 24. And her blood pressure is 188/86. And her saturation of oxygen is 90%. She's also complaining of pain, 5/10 over the right lateral chest. That's intermittent, but is aggravated by coughing and a deep breath, but is relieved when she does not cough and has shallow breathing. So what is relevant and clinically significant that, again, must be recognized by the nurse in order to determine what is going on with Diana? Well, her temperature is 101.6. That is obviously too high, and a febrile response, as we know, is a classic sign of the inflammatory response in a systemic infectious process. Knowing that she had the yellow sputum, we can put 2 and 2 together and see that these two problems of pneumonia, the febrile response, clearly likely have that relationship. Her pulse is 114. That is too high. Why is it so elevated? Whenever you have abnormal clinical data, the nurse in practice must ask one question: why? Now, in the context, her temperature is 101.6. Now, yes, you may see a heart rate, a tachycardia, 80s, 90s to 100, but anything over 110s, likely there's something else going on. And in this context, the nurse must be able to situate the knowledge of anatomy and physiology to cardiac output. That cardiac output equals stroke volume times heart rate. And therefore, if a patient is volume depleted and dehydrated based on having persistent nausea, vomiting, unable to keep anything down, they will be dehydrated, and the compensatory response will be to elevate the heart rate. That is most likely what is driving this elevated heart rate that must be recognized by the nurse as being clinically significant. She's also tachypneic with a rate of 24. That ties in with what we know about the potential for a pneumonia process. Her blood pressure is high, but that's not really causing any problem, likely related to her stress and anxiety. And her saturation is 90%. Again, too low for someone who does not have a history of COPD. Therefore, we can make an assumption that her respiratory status is clearly compromised. Now, she's having right-sided lateral chest pain. Is that an MI? The nurse must recognize that pleuritic-type chest pain that increases with a deep breath, relieves with shallow breathing, is not cardiac in most instances. Never say never. But 99% of the time, this is respiratory. And again, if we have a deep knowledge of the pathophysiology of pneumonia, the nurse will recognize that this is expected, and pleuritic chest pain has a relationship and is often seen with pneumonia. As we look at the assessment, the nurse now does the assessment. She's anxious and uncomfortable. Her breath sounds are clear with coarse crackles in her right lower lobe. She has a non-labored respiratory effort, but is tachypneic with the yellow sputum and phlegm visualized. She's pink, warm, and dry. Her heart sounds are S1, S2. Pulses are strong. She's alert and oriented to place, time, person, and situation. Abdomen soft, non-tender. Minimal urine output. Oliguric by history, again with her chronic renal failure. But her skin integrity is intact, with oral mucosa is dry and tacky. So again, the essence of clinical reasoning must be asked: what is relevant from the assessment data that the nurse just collected? And more importantly, why is it clinically significant? Well, bottom line is with her breath sound. She's got coarse crackles in her right lower lobe. Now, when we have heart failure, that is usually bilateral, and it's in the bases moving up. Unilateral crackles, typically consistent with a pneumonia presentation. And when we know the other data, that certainly is confirming. We're clustering this data, and we're seeing that presentation. We also can look at the fact that she's got the persistent nausea. She has the ability, her skin integrity is intact, but her oral mucosa is dry and tacky. For the adult, I have seen in clinical practice that if you have any question about the volume status of your adult patient, as well as children and peds, open their mouth and see, is their mouth moist and shiny, or is it dry and tacky? If they are mild to moderate to severely dehydrated, the oral mucosa will give you a general barometer that they are volume depleted. And for her to be dry and tacky is confirming that she clearly is dry and is dehydrated. So now let's use our clinical reasoning template, the questions that I have developed as a deconstruction of the theory of clinical reasoning, and ask these questions. Number one, what is the primary problem that your patient is most likely presenting with? If you have a deep knowledge of DKA and pneumonia, it will be evident that even without a physician and lab values to confirm, you are highly suspicious that DKA and pneumonia is clearly what is present in this patient's presentation. Second question, what is the underlying cause or pathophysiology of this concern? It is imperative that the nurse has a deep knowledge of pathophysiology to understand the deeper thinking that's required in the critical thinking for practice. And as we look at DKA, when we know that there is no insulin getting to the cells to basically get that glucose down, the cells are starved. And therefore, when they don't get glucose to burn, they burn body fat. And the consequence of burning body fat is ketones. Ketones in the blood and ketones in the urine. What nursing priority will then guide your plan of care with this patient? As we look at this patient, we have numerous problems here, and this is classic in clinical practice. This is why textbook learning is not beneficial to clinical practice, because it's linear. It's one problem at a time in the textbook, and in clinical practice, we'll see 2, 3, or even 4 problems simultaneously at the same time. And as we see in this patient with Diana, she's got diabetic ketoacidosis, pneumonia, and then the overlay of chronic renal failure. Every one of these has a distinct priority. And so as we look at the nursing priority that will guide our plan of care, we want to use the ABCs. That's NCLEX thinking. More importantly, it's clinical practice thinking. Is there any A, B, or C priorities? And there is. A B priority of breathing. That she's having impaired gas exchange with her oxygenation of 90%. Therefore, this needs to be recognized as her initial priority. But she also has a C priority of circulation because she's volume depleted and she's dehydrated. Therefore, she needs and has that need of looking at IV fluids and all the assessments that are going to go with that. And so as we look at interventions that will base on this priority, we'll look at what that looks like as it relates to B priorities and C priorities. If you are a student, you should know what those are. She also has a non-C priority of nausea. That's a comfort priority, but it's not a B or C. But it still must be a priority. So once you address the B priority, give her oxygen, reassess her, get the IV established, saline, etc., then we can go after the nausea and now give her something, antiemetics, and assessing the response to that. What body system, question 4, what body system will you most thoroughly assess based on the primary or priority concern? Now, as we look at Diana, we do a head-to-toe assessment, but especially with a ER presentation and even in clinical practice on the med-surg floor, you must situate your knowledge to a state. I will do a head-to-toe, but what body system will I most thoroughly assess and do an extra thorough job on based on their primary problem? And for Diana, it's 2. One is respiratory, and so we're going to listen to her not only just posteriorly, upper, middle, lower, and lateral lobes. We're going to listen to her anteriorly, upper, middle, lower, and again, lateral lobes. Cardiovascular, because she's volume depleted, the nurse must recognize the implications of the cardiovascular status in assessing her pulses, her color, her volume status, and all that goes with it. Number 5, What is the worst possible or most likely complication to anticipate? This is where we must be looking for Jason. Jason is the most common complication that could happen here. And as we look at Diana, there's two that we want to be looking for. One is that we could be having respiratory distress. This respiratory distress of pneumonia could spiral, and she could continue to have more distress, lower sats, and that could be a problem. Secondly, we could also see some dysrhythmias as a C priority because her potassium may be off based on her missing dialysis. We don't know that yet, but again, we must anticipate, be looking for that on the monitor. And again, those are things that we want to be assessing and looking for in this context. Number 6, what assessments will you then need to initiate to identify this complication if Jason presents and develops? And obviously, we're going to need to do a thorough assessment of the breathing, the respiratory rate, the O2 sats. For the C for circulation, be looking at not only the heart rate, but as we give fluids, does the heart rate increase or decrease? As we hydrate Diana, we should expect to see that heart rate stair-step down, little by little. If it doesn't, that tells us that she is profoundly dehydrated and will likely require 2 or even 3 liters of normal saline. As we then look, the physician now orders multiple treatments. Physician orders a blood glucose, a 12 DKA, place on the cardiac monitor, establish IV, give IV fluids, chest x-ray, CBC, basic metabolic panel, urinalysis. Question is, it's important for the nurse to, again, situate the knowledge and say, why? Why would a doctor order all of these lab tests? Why would a doctor order a 12 DKA for Diana? That chest pain is likely not cardiac, but knowing that she may be hyperkalemic, what's that going to do to the T waves? And can we see that ST and T wave elevation, especially T waves that are tented with hyperkalemia? And what will that lead to? VTAC and even VFib if our potassium is high enough. Why would the doctor order fluids? That should be obvious. The need for hydration. The CBC looking for, again, focusing on the white count. Neutrophils, most important, as well as the band cells. The basic metabolic panel, looking at, again, at the CO2. And we'll talk about that and see what her labs show up, as well as the urinalysis, looking for signs of infection in the urine. Doctor also orders Zofran and Dilaudid, again, for nausea and for pain. The nurse will then be able to look at multiple orders and then priority set. So if I have a blood glucose, a 12 DKA, put them on the monitor, establish IV, Zofran, and Dilaudid. What do I do first? This will also be an NCLEX question, by the way. Maybe not as thorough, but the principles of how do you priority set? And then practice, again, use the ABCs. That's also an NCLEX thinking as well. So as you look at this, are there any A, B, or C priorities? And there are. Establishing an IV and initiating the fluid is a C priority, as well as even the cardiac monitor. But essentially, the hydration is a C priority, and most likely would be the first thing that the nurse would do. Everything else would be second, third, fourth, fifth, right away. Within 5 minutes, you're having these orders implemented. So it doesn't really, in essence, know what is the most important and then go from there. As we look at her chest x-ray, she has a left lower lobe infiltrate. And again, recognizing this is that, and actually it's right lower lobe infiltrate, not left. She has those crackles in the right, consistent again with that inflammatory process. We get some lab values back. Her white count is 15,000. Her hemoglobin is 9.8. Her platelets are 155. Neutrophils are 92%, and her bands are 3. But it's important, and an important component of clinical reasoning is to then trend what was the most recent and what was the current lab value. Put those together, and do we have a trend that's concerning? As we look at her white count, it's clearly too high, which is expected, knowing what we know because of our thorough assessment that we have done with Diana. And it clearly was only 9.8 the last time she came in. Her hemoglobin is low, but that is within her baseline range of 10.2 from her last, so not a critical concern. And as we know, chronic renal patients tend to run anemic because of the lack of erythropoietin that is secreted by the kidneys. Therefore, they tend to be low. Her neutrophils are too high, and again, why? What's the significance of neutrophils? The nurse must recognize that neutrophils are the first responders to any infectious inflammatory response. Therefore, they're going to elevate and respond aggressively to any acute infection. And bands are within normal range. But what are band cells? Remember that bands are immature neutrophils that represent an acute overwhelming infection, whereas kicking out immature neutrophils before their time. And that is not happening here. Therefore, she's not progressing, at least by her numbers, into a septic shock picture. Basic metabolic panel. Her sodium is 122. Her potassium is 7.4. Her chloride is 98. Her CO2 is 11. Glucose is 729. Calcium 8.4, BUN 88, creat is 6.9. So now using the essence of clinical reasoning, what lab values are most relevant and most important in this scenario? Well, our sodium is 122, very hyponatremic. That reflects the loss of free water. Potassium is 7.4. That is way too high and is a critical red flag that will increase her disposition to arrhythmias, including VTAC and even VFib. Her CO2 is 11. Now, it took me a while to figure this out, but CO2 is not CO2 on a metabolic panel. CO2, though on an ABG, is referred to carbon dioxide. On a basic metabolic panel, CO2 is referring to bicarbonate. Knowing that normal bicarb is 20 to 22 to 26, 28, CO2 of bicarb is 11. She is extremely acidotic and therefore is not unexpected in the acute presentation of DKA. Her glucose is 729, and again, that is extremely high, but not unusual in the context of DKA. And her creatinine is 6.9. If we know that normal is 1.2 or less, with chronic renal failure, though, where this is not uncommon, and you can even see much higher creats, especially if they've missed dialysis. As we look at the physician orders some additional treatments, that potassium is way too high. And one of the things that we can do now we want to get this patient to dialysis, and the physician will definitely expedite that with orders. But one of the things that we commonly see in the ER is that we give 3 cocktails of regular insulin, sodium bicarb, and calcium chloride. Question is why? All of those have a relationship to lowering immediately the potassium level. That is critical. Insulin given intravenously, not sub-Q, intravenously is going to drive potassium into the cell. We give an amp of the bicarb because of the severe acidosis, and we oftentimes also will give a amp of D50 to basically counter the effect of the amount of insulin that has been given that will drive it too low. In this context, that's not an issue. So therefore, we're going to give the calcium chloride to stabilize cell membrane of the cardiac cells. We're also going to start the protocol for insulin IV infusion. And most hospitals have a DKA protocol. And we're also going to start ciprofloxacin, an IV antibiotic, to go after the pneumonia. And so as we evaluate this patient, we have now done all of these interventions. It's been 2 hours later. All primary care provider orders have been administered by the nurse. The insulin is currently at 3.4 units. Dialysis will not be there for 2 more hours. Therefore, we've done our job in lowering, hopefully, our potassium with our intervention of the insulin and the calcium. The physician orders a repeat basic metabolic panel. And now we have some new labs as well based on the current situation. Her sodium now is 127. Her K is 5.1. Again, a drop from 7.4. So we did a great job there. The chloride is 108. The CO2 is now went from 11 to 18. Her glucose is 578. It was 729. We don't want to drop it too quickly, or that can be a problem. So we're moving in the right direction. Calcium is 8.6. Her BUN is 48. Creat is unchanged. And as we look at that, all of our labs are moving and trending in the right direction. A key component of clinical reasoning is trending and recognizing the significance of our trend through a deep knowledge of fluid and electrolytes. So that's why this content must be known deeply by the bedside nurse. And as we do a repeat vital signs. We've been doing vital signs frequently, but now 2 hours later, her current vital sign is a temp of 100.2. It was 101.6. Her pulse is down to 88 from 114. Her respirations is 20, down from 24. Blood pressure is 148 over 84, where it was 188 over 86. Her saturations have increased to 95% on 2 liters nasal cannula. She's also resting more comfortably. She's pink, warm, and dry. She has got, her urine is clear and yellow. Again, not making just very small amounts, essentially with her chronic renal failure. But the bottom line is, we look at this data from vital signs and assessment. She's improving. We can see that with her vital signs. We can see it with her assessment. And so number 2, has her status improved or not as expected to this point? And clearly, because we've done some aggressive treatments and situated our knowledge to the bedside, Diana's improving. And now, does your nursing priority or plan of care need to be modified in any way after this evaluation assessment? Well, as we look at everything, she's still volume depleted. The heart rate's coming down. Her insulin drip is bringing down her glucometers, but she still has, basically, we're not out of the woods completely, but she's moving in the right direction. And last that I situate with my case studies is the importance of caring and the art of nursing. And I think it's always important to step back and ask 2 simple questions to every patient we care for. What is the patient likely experiencing or feeling right now in this situation? It's important to empathize and put yourself in the position of the patient and realize, what's going on and how is this person responding and feeling regarding their situation and what they're in the hospital for. That empathy is central. The second question I think is important to ask: what can you do as the nurse to engage with this patient's experience and show that she matters to you as a person? Patients, as well as all of us, want to matter. And we don't want to just be a nuisance. We don't want to just be a number that's in a room. We want to be a person that matters. And I really want to encourage each of my students that they remember the humanity, not a task that needs to be done, but there's a person that needs to be cared for. And therefore, what can you do to show that they matter? What are those little things you can do that demonstrate caring? That's so central to practice. So I hope you found this case study challenging, relevant, and also something that will allow your students to practice the thinking that's required for practice. And I have this case study available for purchase on my website, as well as many other med-surg topics. And I even have a free download on sepsis that you can download for free on each of my 3 levels and see for yourself how these case studies can really benefit your students in the learning of that is required for practice. So check out my other videos on my YouTube channel, Think Like a Nurse, as well as follow me on Facebook at Think Like a Nurse, and follow me on Twitter at Keith Rischer, RISCHERRN. And remember, in closing, that clinical reasoning is not just a trendy pedagogy to flip your classrooms, but these can demonstrate and allow your students to practice the thinking that will prepare them for clinical practice and promote better outcomes for the patients that they will soon care for. Thank you.